Spine Institute. We're getting ready to perform a Deuk Laser Disc Repair on a patient who has a herniated disc that's causing pain in her upper back where the thoracic and lumbar spine meet, specifically T11-12, which is really at the junction. It's an unusual place to have a herniated disc that's symptomatic, causing pain, but this is where this patient's pain is coming from. We've tried epidurals, we've tried facet blocks, we've tried pain meds, we've tried therapy, massage, everything conservative. Nothing's worked. She continues to have horrible pain from the spinal herniation, specifically called a disc bulge at T11, T12. On the right side, good job. Let go, let go. Nice job. Sam. Perfect. So the challenge is that we're working in a very unique place because unlike the normal cervical spine in the neck and the lumbar spine, there's ribs at T11, T12, and we're going to have to try to navigate around the ribs. Makes it a lot harder to do. If this herniation was any higher in the thoracic spine, I wouldn't be doing this surgery. But because it's T11-12, I'm willing to try to do this. This is Dr. Deukmedjian. Are you okay? We're going to get started. I need you awake in the very beginning to help me out, okay? Alrighty. Well, the first thing we need to do is we need to localize to where we're supposed to be. So, yeah, put that down for now so you don't do anything. We've got an AP, right? Good, good, good. Let's get a shot and see where we are. All right, so that looks like the T12 rib. So I need to be slightly higher. Shot. That should be T11-12 right there. You agree? All right, thank you, Luis. I'm glad I have somebody agreeing. That should be T11-12 right there. That should be a good entry point too, right around here. Let's have some num-num. Actually, my initials were perfect on that spot. Alright, so I'm going to give you a little numbing medicine, okay? You'll feel a little stick and burn. That's normal. Don't freak out. I'm sorry, this is probably the worst part of the whole surgery. Hopefully. Sorry about that. We raise a little wheel. Yep, I apologize. All right. So, we got to navigate between the ribs. And that's going to be the hard part. I'll give it a second to work. Is that more comfortable for you? Shot? All right. Now we want to aim for that disc. Where do you feel that? Huh? Right where the sharp part is, huh? All right, I'll try to give you a little more numbing medicine. Just lay still. You're doing great. No, no. Well, you do what the anesthesiologist tells you to do. So our patient's awake, as they all are, during the surgery. And I need her help making sure we don't get too close to any of the nerves. AP. Okay, let's go back to a lateral. We're going to use the x-ray machine going front to side. We call the front view, front to back view, AP, anterior, posterior. Posterior means back. We call the side to side view a lateral view. Let me know when you got it. That's it there? Yes. Alrighty. So We're going to have to aim a little more anterior. You can see the lung shadows. We're pretty far posterior. Shot. AP. We're going to need to get those pedicles lined up a little bit better. You're doing fine. Everything's going well. So I think we'll need to wag it from that view you had. Let's just make sure we're heading in the right direction. It looks like we are. Okay, let's go back to a lateral view, please. Okay, that's again the 11-12. You can see the 12 rib down below attaches to the 12 vertebral body pedicle. All right, I need to wag a little bit. Just a little bit, like 2 degrees max. Let's see if we can get a better picture. It's almost perfect. I think that actually is better. What do you think, Luis?
I think it's better.
Yeah. All right. Well, that's the facet joint.
Here for you, okay? Don't move. Is you okay?
Shot. Are you comfortable?
Pressure. Oh,
In your back?
yeah.
Shot. Where do you feel that?
Oh, the pressure with the shot was.
Uh-huh. Give me an AP. You're doing great. Just lay still. Shot. Okay. Let's go back to a lateral view. Are you still okay?
Yeah.
Let me know if you feel anything by your legs or feet, okay?
Okay. You were even in my feet.
Huh?
Even in my feet. Feel even in my feet.
Yes.
Okay.
Yeah, that's what we're wondering. We don't want you to, but if you do, let me know. Okay.
Yeah.
Now let's see. Let's try to get those facets lined up a little bit better. I think some of it's wag. Try a little more wagging. Just a degree or 2 maximum. Let's see where you are now. That's I think that's better. Well, it's kind of hard to say. Let's get an AP view. Alright, so it's not bad. Not bad at all. You can see the spondylosis there, some of the bone spurs forming. Alright, let's go back to a lateral view. She's got degenerated disc with spondylosis at multiple levels. This is where her pain localizes to, and this is the one that's herniated on her MRI. Where do you feel that? Sean? Where do you feel that? Where? Don't move. Where do you feel it?
Oh God.
Okay, okay. Stay still.
Where do you feel that, sweetheart? In your back?
Don't show. Don't show.
Just my back.
Yeah. All right.
Just the back when you shot me.
You felt a shock in your back?
Yes.
All right. That's just us moving through, getting to the area there where the disc, the bad disc is, okay? Just relax. Just relax. Everything's okay. Still sore? Shot? That's just your facet joints.
Oh God. Oh.
Shot.
Oh.
Yep.
Oh. Oh.
Shot.
Let it run for as soon as you have it, sleep, okay?
Okay.
You can do it.
Okay.
Shot. What's the issue?
The patient, in fact, you has had 4 milligrams of Zofran and still having nausea.
Okay, maybe we must have it Zofran or Reglan and another Reglan.
Reglan? Okay.
Well, you can do more Zofran too, right?
He's had 2 already.
He got
2 fours.
2 fours.
So he's at 8, and how long?
Is in noon time.
Yeah, I mean you can go for every 4 to 6 hours, right?
Yeah,
What time is it now?
dilation if you give too much.
Shot.
How you feel now?
Shot. Is that it there?
Yes.
Give me an AP. You're doing great. We're almost done. Yeah, that's good. It's really good. All right. You can see she's rotated a little bit. You see how the spinous processes are not in the middle? Let's get those straightened out between the pedicles.
He's throwing them down, actually.
Did he have an NG tube in?
Did not.
I'm sorry. AG?
Mm-hmm.
No, that could be the.
I need you to get those spinous processes in the middle. Okay, go back to a lateral. That's looking good. Everything okay with her?
Yeah, it's the blood pressure part, the cable that you're seeing.
Yeah. All right, maybe we can do this a little bit to get the back of the vertebral body lined up properly. I think that might have been, I can't tell, it may have been a little bit worse, but let's see. Try the other way, as you said. I think that's better, right? Yeah, I think that's better. It's hard to say though. It looks like the facets are offset. So how about some wag? Are those the facet or is that the back of the vertebral body above? Try a little wag shot. I think that's better, right?
Yes, sir.
Are you okay?
Yeah.
All right, you're doing really good. This is the hardest part of the surgery because you're awake for this part. Shot. AP. We're gonna hopefully get to put you to sleep in just a minute. Then when you wake up, we'll be done. Shot. Where do you feel that? In your back? All right. Lateral. Shot. Are you okay? Good job. Just lay still. If you have pain, tell me. No, nothing down your legs, right?
No.
Great. Shot? All right. Did you feel anything there?
No.
All right, well, that's 11-12. Let's get an AP. Just to verify that. We're going to put you to sleep, okay? Lay still.
About a month.
What?
About a month would be good.
Oh, right, yeah, for a month.
Yeah, they're good.
Okay. So, I see 11. I see 12. I see the rib of 12 to the pedicle of 12. I see the rib of 11 to the pedicle of 11. That has to be 11, 12. Then the one down below would be 12, 1. And the Raytech is over 1, 2. Go ahead and take a shot. All right. We are definitely in good position. So let's go ahead and get this done. You're going to go to sleep. When you wake up, we'll be done, okay? Count from 1 to 100 out loud for me.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
I would just call the discogram, where are you? We're going to have to call it unreliable. Yeah, yeah. We did it, but we didn't get any response. And I think that she had some pain medication because she didn't feel anything when I went back to that same area. So it's better that she's not jumping off the table, though. Keep counting out loud. Give me a shot. Shot. Keep counting, shot. Is this thing moving back? Shot. I think we're there. Shot. Yep, we're there. All right. How's she doing? Is he...
He just threw up about 20 milliliters of like acid bile yellow colored.
Uh-huh.
And
He's awake, though?
yeah, he's awake. He's doing okay.
So he's protecting his airway.
Yeah. Breathing fine. He's moving around, talking.
That was our blood pressure.
Check it again.
It was at 130. I want it down.
We started with 170 refer. She have a severe aortic stenosis, not severe aortic stenosis.
Really.
Trying to go
We're going to do cervical scope.
cervical.
Yeah. Let me know when you have a pressure. 116 is fine. Yeah, that's fine. Knife. Let's make our incision. What is it, guys? Okay, that should be good. Knife is down. All right, at this point, we're going to be putting our tubular retractor in. And once again, give me a lateral, please. Shot first, then lateral. Yeah, lateral. So it's a beautiful transforaminal approach. Very difficult to do at this level. Guys, is that my lateral? Thanks. We're using a very skinny little tube to do the surgery. And shot. Passing the facet joint right now. We're not using the full lumbar system that we use normally in the lumbar spine. How's she doing?
Good.
She okay?
Yeah, she's a mouth breather.
A mouth breather. Shot. Okay. So right now we're at the disc on the lateral view. Shot. AP. You can see that the disc has a big tear in the back. It leaked the dye out. That's the black dye running up and down the spine behind the vertebral bodies. It's just anterior to the dura, which is where the spinal cord is and the nerves are. It's looking good. Can you go back to a lateral, please? We're right on the medial border of the pedicle. So if I had to say where we were in the foramen, are we more medial or more lateral? I'd say we're a little bit more lateral, which is where we want to be in the thoracic spine. But honestly, I think we're perfect because we're right at the back of the disc right now. And the good news is I can advance this mostly with my fingers. Shot. Shot. All right, so we're in the disc. I'm going to take the guide wire out. Mallet. Grab it. Uh-huh. Shot. Shot. All right, perfect. Now, the whole surgery, this thoracic disc repair, Deuk Laser Disc Repair, is done through a tube this big. It's just 4 millimeters, super tiny. How's her lung function?
The blood pressure cuff is right now.
How's her pulmonary function? Good?
The blood pressure cuff is on the other.
Yeah. I mean, obviously, one of the risks here is the lung, but we're just behind it, but it's close, so we have to be careful. If you notice anything, let me know.
Sure.
Shot. 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 We're inside the disc. Shot. Right in the tear. Shot. So at this point we don't need to go any further. Here's the dilator. Now we're ready to put the scope. I need the fluid adapter. Nice job. You yeah, you can go out. That's correct. That is correct. Huh? Yeah, let's see. So get a wet Raytech ready. There's a little bit of disc material. Just use your fingertips, don't use your palm. Okay, try to save those fragments if you can. The what? The fiber? Alright, I can do that. Just give me a blue towel here. The blue towel will help direct the irrigation into the bag, okay? You do it like this. The irrigation is going to want to go on the floor. But by having this here, it makes it go in the bag.
We need the, can we move the monitor closer to you?
Did it touch?
No, no, sir.
You're sure?
Yes, sir.
Monitor's fine. Alright, so see it came out the bottom? Just bring it in a little bit. Turn on the irrigation. Close this a little bit. And we're ready. We're going to do 15. Sorry, 20. 20, right? Yeah.
Okay, so
I don't want to do 30.
wait 1 second.
Oh. She okay?
Yeah. I needed to.
Yes.
She not.
Yeah, so I can have her a little more awake at this point.
Sure. I just stop everything.
I need more light in the wound. Okay, that's better. I may need more. All right, that's good. So there's our herniation and our tear in this disc. On. On. Good. It looks good. We are inside the herniation, folks. T11-12. I don't do a lot of thoracic disc herniations because they're not common. I mean, they don't cause pain typically. So
Yeah, all the way. Yeah, please.
Any questions from our audience? Sean?
None so far.
This is all scarred from the herniation. A lot of scar tissue. Watch the wire, don't let it hit me. If it hits me, we got to stop the surgery and get a new wire. Because then it's contaminated, okay?
Okay.
So be aggressive. You understand?
Yes, sir. Listo. Point back forward, please, and steady, please. And, okay. Thank you very much.
So the nice thing about this technique is that we can fix this disc herniation without actually taking bone away from the spine. And in the thoracic spine, you'd have to pretty much take enough bone away on the side that you destabilize it. Patient would need a fusion. This patient doesn't need a fusion because we're not removing any bone. We're just taking the herniation, repairing the herniation and the disc tear. So we're not actually removing bone from the spine. So this is a completely different approach than traditional spine surgery with removing bone and fusing. We're actually repairing this disc percutaneously, not percutaneous, but it's not really percutaneous because it's being done with an incision. But that's the way some people have published it in the past. But it's actually transforaminal, very small incision, so it's called minimally invasive. And it's endoscopic, so it's endoscopic. Minimally invasive endoscopic surgery. And the specific procedure is called the Deuk Laser Disc Repair. It's the only surgery in the world that repairs a herniated disc rather than removing the herniation or fusing or artificial disc. The Deuk Laser Disc Repair includes performing an annular debridement, which is what I'm doing right now. The annular debridement will let this disc heal properly in time, naturally, without any metal or fusing or artificial disc. None of that stuff is necessary. What makes it possible is this debridement I'm doing right now of the annulus. There's no other surgery in the world that does an annular debridement except the Deuk Laser Disc Repair. We're the creators, pioneers of that technique. Any questions from our audience, Sean?
Not at this time, no.
All right. We're going to be done in 10 minutes.
Okay, sir.
This is all the blue stuff is the tear and the herniation. We're going to be done in 10 minutes, ladies. Huh? What does that mean? Oh. Okie dokie. This surgery is not available in England at this time or Europe. I didn't pick on England in any particular reason. We just have a lot of people from England interested in it. This surgery is really available only in the States and specifically in the state of Florida. It will become more widespread in the future as more surgeons are trained to do this procedure safely and effectively. I'm very particular about who I work with, whether it's a nurse, a technician, or an MA. And I can tell you, the surgeon that I trained to do this, I haven't even trained my own brother, who's also a neurosurgeon. I haven't trained him. Why? because I don't think he's the right doctor to be doing it. That sounds pretty harsh, but the truth is he's actually a pretty good neurosurgeon. He does spine surgery just like me, but he does the more traditional type surgeries with fusion. And he's a technically pretty good surgeon, but I wouldn't train him to do the procedure either. So it takes a really special kind of doctor for me to want to train. And why is that? Because it's actually has to be done perfectly right. You have to have tremendous attention to detail. And my brother, who's a neurosurgeon, he trained at a different institution than I did. He trained in Tampa, which is a good program, University of South Florida. It's not a great program, but it's a good program. And he just doesn't have the same attention to detail as I do. And if you don't have an attention to detail, you'll end up hurting somebody badly. All right, I'm 2 minutes out. There was the herniation. This is the last of the tear, right here. So it should heal nicely. All right. I'm going to pull it back just a little bit. Give me a second. Sorry, Luis. Give me a... Almost done. Just clean this stuff up a little bit on our way out.
We have a question.
All right, I'll take it.
One of our viewers is wondering, what is the downtime that this patient will have to experience after the surgery?
Oh, great question. Downtime, no downtime. Literally an hour, and then they're going to be up walking around on their feet. No downtime. This is, did you see the incision? I'll show it to you when we're done. But quite literally, it's 4 millimeters. 4 millimeters will look like a pimple, and there's really not a lot of pain from the procedure itself. So I would say just 1 or 2 hours of recovery today, and then they're done. Okay? This is the outside of the herniation. I've only done 2 thoracic disc herniations in all my surgeries, all my laser surgeries, for now 14 years. Why is that? Well, most important reason is not many people have symptoms from a thoracic disc herniation. Most of them are asymptomatic, meaning they don't cause problems for people. They literally just have it, but it doesn't do anything. But in a few people, that herniation causes so much pain and discomfort or spinal cord compression that they end up needing surgery. Now typically they would get a fusion, a decompression and a fusion. This patient didn't want a fusion. They wanted me to try to do the laser surgery, and I agreed to do it because I thought it could be done safely. There it is. looking from the outside into the disc herniation right there. The rest is soft tissue. All right, we're done. Watch your face. Don't let it hit. It almost hit your mask. You can't let that happen. All right, dilator. So let me show you. Just, can you get it a zoom in on here in a minute? Let me show you what we did, how we did it. Okay. So you guys see this? Let me have a Ray Tech. Okay. I'm going to put a little pressure. Take this out. We did the whole surgery through this tube. You all see this tube here?
Yes.
Okay. Whole surgery was done through that tube. And I'm going to show you the incision. Right here. It's about a 4 millimeter incision. All right, let's put some pressure here for a few minutes. There's no bleeding. We lost 2 milliliters of blood. All right. And then you guys are going to have steri-strip.
Yeah, we are ready for that.
Good. Okay. Okay. Blood pressure is good. Perfect. You guys are all good. Any other questions from the audience? That was...
None currently.
All right, that was a T11-12 disc herniation. It was not a big one, but it was significant, and it kept plaguing the patient. She's had horrible pain, and we've tried everything from shots, epidurals, medial branch block, rhizotomy, therapy, medications, muscle relaxers. We tried everything, and nothing's worked. So she was either going to have a fusion there, or we were going to try the Deuk Laser Disc Repair to repair that herniated disc. And that's what we did today. So we'll follow up with her in a week and see how she's doing. No complications, 2 mils blood loss, and DLDR, right approach, T11-12. I'll take some paperwork with me. Go ahead and type up your questions, folks, and I'll head over there and I'll answer them for you. Good work, everyone.
All right, thank you for joining us for the post-op Q&A. We have Dr. Deuk in the room with us, ready to answer some of your questions. The first question was submitted to us via our Deuk Spine Institute app. The question reads, I read a lot about minimally invasive surgery, and now I'm seeing articles about minimally invasive TLIF surgery. What is your opinion on that technique? Are there any advantages over DLDR?
Well, first of all, that is a wonderful question. Thank you for asking. And thank you for using our app. Our app, the Deuk Spine Institute app, is free, as everyone probably knows that's downloaded it. It's available on the Apple iOS platform and the Android. We don't discriminate. So whatever phone you have or platform you have, you can download the app. It's free. We hope that the app is useful and that it has good information. One of those things it allows you to do is to communicate with our team during surgeries like this, so you can ask questions of me and the team. The question was, what do you think about minimally invasive TLIF? TLIF stands for transforaminal lumbar interbody fusion. This is a surgery I do all the time. If you watched this channel enough, you'll see that I do TLIFs almost every other week. We did one, I think, last week or the week before. So it's a complicated question. The second part is how is the Deuk Laser Disc Repair different or better? So I'll give you the short answers first of all. Minimally invasive TLIF, if it's done properly, which I do pretty much minimally invasive TLIFs. Somebody may say, no you don't, but yes I do. And then the comparison of Deuk Laser Disc Repair. The Deuk Laser Disc Repair is a much better surgery because with the Deuk Laser Disc Repair, we're not opening the spine, we're not cutting the muscles, we're not damaging the muscles on the way in, we're not cutting bone and removing bone like you do in a TLIF, we're not putting a cage in between the bones, we're not fusing the bones together so they don't move anymore, we're not putting in screws and rods and hardware and plates and stuff like that. It's just a natural repair of the disc. It's a much more advanced, sophisticated, better surgery than any TLIF or any surgery other, that's a fusion or requires removal of bone like a microdiscectomy or laminectomy. The Deuk Laser Disc Repair is the safest, very best surgery in the world, and it will eventually replace all the TLIFs being done out there, minus a few that are being done for degenerative cases like scoliosis or really bad listhesis or flat back deformities. Those are more deformity cases rather than just simple treating a herniated disc that's symptomatic. So let's rewind a minute. Are my TLIFs, if you've watched them, are they minimally invasive? I would argue they are. And here's why. A minimally invasive TLIF is, the whole concept of minimally invasive means smaller incision. And what I found with the minimally invasive TLIF techniques is that the surgeons are making incisions on the side of the spine rather than directly in the midline, and when they do that they have to go through the muscles that are there, and they really damage the muscles quite severely. Now they won't say they do, but they do. I've done minimally invasive TLIFs in residency, and there's a lot of muscle damage and removal. You have to cut through the muscles and damage the muscles. So minimally invasive TLIFs are done with smaller incisions, but here's the thing. When you add up all the incisions that are made, they actually equal and are usually longer than a regular midline TLIF incision, an open TLIF. So there really is no benefit from the length of the incision when you add up all the minimally invasive TLIF incisions, because you got to make an incision for the cage, which happens to be the same incision you use to put your screws in on that side, plus you got to make an incision on the other side of the spine to put the screws in on the other side. Now some surgeons will do just the one side incision and they put screws in only on one side, but that's bad biomechanically and has a much higher likelihood of failing to fuse. So you don't want a single incision, one side cage and screws without putting screws in the other side. Plus when you put the screws in on one side and you compress them to keep the cage from popping out, you're actually creating scoliosis. So you really need to compress both sides. Well, those surgeons that do a unilateral one-sided minimally invasive TLIF with screws are actually doing more damage to your spine, and I would never, never, never let them do that surgery. Because what they're going to do is they're going to put screws in on the left side that they go on, where the cage is, or the right side, depending on which side they prefer, and they're going to have to squeeze those screws together to hold the cage in place, keep it from popping out backwards where it came in. So when you do that, you're creating scoliosis. You're creating a iatrogenic, surgically created curvature of the spine exactly at that vertebral body. You do not want that, because then you're going to compensate for that curve at the levels above and below the fusion, and you're going to develop a compensating curve scoliosis, the opposite direction above and below that unilateral one-sided TLIF. So I'm strongly against unilateral TLIFs, and if you're going to do a bilateral minimally invasive TLIF, then the incision is just as big on both sides when you add them together as the midline incision that I do. So now let's look at muscle damage. My technique has no muscle damage in the midline when I do a TLIF. The minimally invasive TLIFs damage the muscles massively. There's tremendous scar tissue from the damage after surgery. Then let's look at recovery. My patients go home in 2 hours after an open TLIF. The quote-unquote minimally invasive TLIF, they usually stay overnight in the hospital. Sometimes they go home the same day if it's a single level, but I can do 2 and 3 level TLIFs and go home the same day within 2 hours. If you're doing a minimally invasive 2 or 3 level TLIF, where you're going through the muscles, the patients are going to need to be admitted and watched overnight, at least overnight, and usually for a few days. So my discharge is faster with the open TLIF that I do. My muscle damage is less with the open TLIF. Our incisions are the same size, and my results are second to none in terms of eliminating back pain and leg symptoms. They're 95% each, and you can't do better than that. Sure, I have 100%. It's about 50% of my patients are 100% relief of back pain and leg pain, but my average is 95, and that's a really, really high average. Then let's look at complication rate. Minimally invasive TLIF versus Dr. Deukmedjian's Deuk Spine open TLIF in the midline. We've had less than 1% complication rate, whereas with typical minimally invasive TLIF, you're looking at a 5 to 10% complication rate. So that's 5 to 10 times higher. So no matter how you shake it down, the quote-unquote minimally invasive TLIF that most surgeons do does not result in a better surgical outcome than a Deuk Spine Institute regular TLIF in the midline. There is absolutely no benefit. Even blood loss, my blood loss is less than their minimally invasive. So unfortunately, minimally invasive has become this marketing term, tool, that a lot of hospital surgeons, implant companies are trying to use to capture more patients. And in the end, what matters, in my opinion, are the hard specific results or numbers. You know, how quick was my recovery? How much of my pain did you get rid of? Did you cause a complication or not? Am I able to return to normal activities very quickly? And when you look at all those factors, truly the TLIF that we do in the midline is better with respect to all those outcome variables for patients than a minimally invasive TLIF. And then comparing any TLIF, my TLIF versus a minimally invasive TLIF, to a Deuk Laser Disc Repair, the Deuk Laser Disc Repair is hands down, by far, neck and shoulders, torso, abdomen, pelvis, and even knees ahead of a TLIF, because it's a tiny little cut and we're repairing your disc without metal or fusion or anything. It's just natural repair with a laser and then coming out and sending you home. So that's definitely better than any fusion. Well, we have no other questions. I'm speechless. I can't believe it. But I got to say, the questions we've gotten today have been really, really high level, very thoughtful, very insightful, and really stimulate great conversation for learning and education. I'm glad you all were able to be here today to watch. I think this last surgery I just did, the T11-12 Deuk Laser Disc Repair right side, that's the first T11-12 I've ever done. I've done a T12L1 before, but I'm not saying I'm going to make a habit of it, because it is a lot more dangerous with the spinal cord being right there through a lateral approach, but also the lungs and the aorta and all kinds of important, structures like kidneys, ureters, etc. but I felt that I just kind of nailed this one today, and I felt really good about it. And honestly, I was ready to abort the surgery should I need to. Should I feel that for any reason things weren't going perfect, I was ready to abort. And I told the patient that ahead of time. I said, listen, I'm going to try it for you, but if things don't look right, I'm going to abort. And I said, you probably have about a 75% chance I'm going to get this done. There's about a 25% chance I'll pull the plug and not do it. And you're going to be disappointed that it didn't get done. But fortunately for this patient, everything went well. She did have some pain as I got closer to the disc. A lot of pain, as a matter of fact. She almost came off the table because it was so painful in that area. So the anesthesiologist had to give her some pain meds, IV, to kind of calm her down. And when he did that, I did the discogram while she had those pain meds on board. Of course, she didn't have any pain, but she had a big tear. Dye leaked out, went into the epidural space, so I'm sure we're in the right spot. And I confirmed it with the AP view with the ribs. So I know I was at T11-12, and I felt it went absolutely perfect. Couldn't have gone better for her. So I'm hoping, fingers crossed, that her pain is going to be gone like I expect it to be, and she's going to be a happy camper afterwards, satisfied with the results of the surgery. That being said, I feel very lucky we got this done today. It's my first T11-12. I've done T12L1 and everything below that, of course. So I don't think I'd go any higher than that, though. I think T11-12 is probably the lowest I'd do. So for those of you who asked me in the past, will you ever do thoracic? My answer is I would consider doing T11-12, T12L1, but I wouldn't do anything higher than, T11. Hope you have a great day. Everyone stay safe. Stay away from COVID-19 and protect yourselves and your family. Wash your hands. Use a mask as appropriate. And I look forward to being together with you all next week for some more